I'm actually an infectious diseases physician like David Denning, but actually I'm at Imperial College London, so I'm an academic, and I mainly work on the immunology of Aspergillosis fumigatus responses essentially. And over the last 15 years I've been in that area and essentially also treating patients with fungal disease. Initially at the Hammersmith and Imperial Healthcare, which is one of the largest healthcare trusts in the country. But in the last 18 months, I've actually moved to the Brompton, where there's a lot of patients who've got chronic Aspergillus infection. I've set up a fungal disease clinic and lots of MDTs and things there. So we've got now quite a nicely established service looking after patients with fungal disease at the Brompton. And in addition to that, we're now starting to do a lot of research on those patients to complement the research we're already doing on the immune system. So I think it's been a really good move for me in that I've done a lot of lab research on Aspergillus immunity using animal models and healthy volunteers and things. But now that I've moved to the Brompton, we can actually start to look more complex way at what's actually happening to patients and what's causing them to run into these troubles. So that's essentially where I am at the moment. So I think I was asked to come and talk because we may be setting up a satellite centre at the Brompton, and I mean that's interesting in itself because I don't know if any of the patients here are from the Brompton. In fact, okay, yeah. So essentially, there's an enormous cohort of patients at the Brompton. I don't think it's as big as Manchester, but certainly we've got about 500 or 600 patients, CF, non-CF patients who've got chronic respiratory disease. The setup is quite similar to Wythenshawe in that there's also a large lung transplant unit, in fact one of the largest units in Europe. So we've got a large lung transplant population, and many of those patients will develop fungal disease as well. So there's kind of pressing internally need to set up a good centre there for the patients already at the Brompton. And I think on top of that, certainly David, when he initially talked to me about this, was mindful that there are many patients in the south of the country who can't actually easily get to Manchester, and it might be useful to have like a collaborating centre in the south that can help share the burden and try to deliver some of the services. So if you've got any questions for me about any of that, I'll be very happy to answer. As far as I understand it, there are some discussions I'm not involved with because there's something called a respiratory CRG, which is essentially the quango or group, whatever you like, that sets it up. I'm not a respiratory physician, so I'm not in that CRG, so I only hear from people like David and my respiratory colleagues at the Brompton. But I think something's happening this year, and if it goes live, it will probably be first or second quarter of next year that might come around, essentially. So fairly soon. We've got all the kind of service set up that we need to deliver that. And at the moment, we do actually receive referrals from other trusts all the time anyway, so we're kind of doing it anyway. It's just that it would be nice to formalise it, and also within the NHS culture there are certain income streams, etc., that need to be sorted out that will enable us to make that a sustainable service.
Yeah, I can answer that because that's down to the specialist commissioners who
Yeah.
have allocated the money to Manchester as the first centre. But we recognise that we need something down at the Brompton to assist us because people find it difficult to travel. So they're just working out how we would actually put the pot of money there, if you like. So it's just down to finances, how we would allocate that to your service and your staff and drug monies and so forth. So it's just working out how that would operate, and then we'll be good to go.
I think that we haven't actually formally discussed that actually, but I mean at the moment it's a quite naturalistic process in that we're already receiving referrals, and then I guess we would have to talk to David at Manchester and also obviously the patients as well about who would want to potentially access that service. So I don't think we've got a unilateral approach to it.
And I don't think it would matter where people were. It's what would work for them, I guess, because at the end of the day, the idea is that the pot of money for that group of patients would be allocated. So whether they would prefer to go to Brompton or Manchester, it wouldn't really matter, I don't think.
Yeah, and the money would follow the patients.
That's right, yeah. So.
So the way that works in NHS organisations is it essentially grows with the population. So there's quite a reactive process internally to build up the service. At the moment we have quite a well-stocked service, but if, for instance, things went 3 or 4 fold up, as they did in Manchester, then much like in Manchester, we would quite quickly have to take on extra staff. And I think when David had his centre in Manchester initially, it was more or less just him and a couple of other people, and then suddenly they were inundated. I think they had about 1,000 patients within a year. Or something. I don't know if that's right, but something like that. And he really had to recruit people very quickly to support that. So we will grow it organically as the requirements drive it. I think the bottom line is that my impression, having worked, in the southeast quite extensively and taken referrals from a lot of patients, is that there probably are a lot of patients in the south who at the moment are not even aware that there's a National Aspergillosis Centre, and a lot of those people could potentially be sort of sucked into our centre if we publicise it right in the right way. So I think there could actually be a benefit in terms of bringing people into the fold who before hadn't necessarily been able to or even known about accessing those services. So yeah, it could be quite a lot. Yeah, I think there's a key issue around advocacy actually, and also about education. I think one of the things that's been really difficult in the field is that diagnosing a lot of these conditions is quite difficult. It actually needs experts and some of the new tests that are coming in, and also because many of these infections affect people who are already ill, but not necessarily people who are completely healthy. There's perhaps been less awareness of Aspergillus in the lay public when you compare it to something like meningitis, for instance. So yeah, certainly publicising, which the Manchester Centre have been outstanding at, is going to be a key component of trying to make sure that all the people are accessing the right service. I think that actually even at a governmental level it's been something that's not necessarily been recognised, and that's even at a global level. And part of the issue here is that you need a critical mass of people to drive advocacy for a certain condition, and because this has been a sort of neglected condition historically, that we're now actually beginning to build up the critical mass. That's evidenced by the great meeting we're having this week. But it does take time, really, decades even, to get that mass and to get things into government policies. It's broadly, if your asthma is difficult to control and you fall into that group of patients who are not responding to the first-line therapies, then they would test you. But you wonder whether or not upfront systematic screening would then identify people earlier and potentially stop lung damage happening before it's too late. There are two issues. One is that a proportion of patients thought to have TB will actually have Aspergillus up front. And then the other issue, I don't know if this applies to you, is that people who've got cavities from TB can then get secondary infection with Aspergillus into those cavities. So, so certainly in the patients who've got severe cavitation, they ought to be followed and tested for Aspergillus. And then obviously up front, I guess, if they haven't clearly found TB, then they need to be thinking about other things. And again, I think that's about educating our colleagues who are, in the broader infectious disease and respiratory fields. If you're talking about the fungus mutating, then there's emerging evidence, and actually we're also involved with this, that the fungus can adapt to, the individual essentially, and then behave depending on that individual's, underlying respiratory problem in different ways in order to persist in the lungs. So I think it probably can mutate or sort of be naturally driven to behave in a specific way so that it can persist in someone's lung. And then, you know, there is also an issue of resistance to drugs, especially with the azoles and possibly with other drugs. So that's another way that it could mutate. So that's an emerging field, and I think one area that needs to be looked at, which is less clear, is whether or not there are different forms of Aspergillus fumigatus, and some of them are more likely to cause asthma, and others are more likely to cause sort of infectious aspergillosis, like Aspergillus bronchitis. And there's some interesting animal work that suggests that might be the case. And of course, if that is the case, then when we initially find an Aspergillus in someone, we can have a look at it and then try and predict what kind of disease they're going to get. That could be a really interesting and useful area, you know, for patients as well as doctors. So there are lots of interesting questions about, is it all the same fungus, or are there different funguses? What does it do when it's been in your body for 10 years, etc., etc., etc.